All right. So with that introduction, I have the chat open. So if anything that I say is dead wrong or dead right for this audience, and please feel free to challenge, participate, and let me know your thoughts. So this lecture series is entitled Emerging Threats for the Frontline Provider. And it comes out of the desire to help make sure that we within our group at the Center for Global Emergency Care are helping make sure that others have access to information that we may have access to, and that we're sharing that information in a digestible and enjoyable way. This is going to be a real whistle-stop tour, and we're going to go through some content that I hope will be interesting and enjoyable for you. So why emerging threats? And I really like this quote from Dr. Fauci, which says that the emergence of new infections and the reemergence of old ones are largely a result of human interactions with and encroachment on nature. As our human societies expand in a progressively interconnected world, and as the human-animal interface is perturbed, there's opportunities that are created, and these are often aided by climate change, for unstable infectious agents to emerge, jump species, and in some cases adapt to spread among humans. Fauci also said this a little bit more succinctly when he said, it ain't over till it's over, but it's never over about COVID. Emerging and reemerging infectious diseases are just a part of life, and they're a thing that we need to deal with as frontline providers. When we think about emerging threats, it's important to know that they're really challenging to predict in advance. The historic prediction of the next pandemic has mostly been wrong. What diagnoses we're talking about tend to be those that are either suddenly increasing in caseload, suddenly increasing in geographic spread to places that they haven't been before, or suddenly increasing in incidence. And those pathogens sometimes are novel pathogens, like COVID-19 was, reemerging or resurgent pathogens that we thought were either on the way out or were a variant that was less pathogenic, or are deliberately emerging. And that's when we come to things like bioterror threats. Our systems are fragile. Everything about the last 4 years told us that our systems are easy to break when something happens that's not an everyday occurrence. And so that means that surveillance and response for emerging threats depend on frontline providers being able to recognize, flag, and respond to emerging threats. And that can only happen if people have access to information, hopefully like the information that this lecture series is designed to provide. So why am I the person talking to you about this? I'm an enthusiastic educator, if nothing else. I'm the education lead for us here in the Center for Global Emergency Care, and I teach emergency medicine as my full-time job. I'm also a tropical medicine geek. I'm certified by the American Society of Tropical Medicine and Hygiene in clinical tropical medicine and traveler's health. I'm really interested in the concept of time-sensitive learning, which is the idea that sometimes we need info, and when we need it, we often don't know right before that moment that we're going to need it. I think that working on issues around searchability of info, digestibility of info relate to this. And so I really love the idea that I can be involved in helping people learn this kind of time-critical material just before or right when they need it. And I'm one of all of you. I'm a fellow frontline physician. I work a full clinical burden as a nocturnist in a high-needs region of Baltimore, and I care for people with these illnesses who come to us from all over the city and all over the planet. Our first lecture is going to talk about MPOX, and that's twinning with the journal club that we just completed earlier in our meeting. So a little bit about MPOX basics. There's two clades, but you can't tell which clade someone has, what type of MPOX they have, just by looking at them. And then within each of those clades, which you can think of as sort of genetic families, there's subclades. And the two most recent outbreaks that we'll be talking about are from subclade 1A and subclade 2B. MPOX is transmitted skin to skin, and that skin to skin contact can include living in close quarters and sharing, for example, bed linens, or it can include sexual contact with a person with MPOX. And I mention that because there's misperception sort of on both sides of that line, that it's only a sexually transmitted disease, or that it can only be transmitted through some other ways that, for example, smallpox is transmitted. Neither one is true. It's primarily a skin-to-skin disease in most of its clinical manifestations, although there are other ways that it can be transmitted. It's a vaccine-preventable disease. So Jynneos is the vaccination that is currently recommended by the CDC. 2 doses are recommended for maximal protection against MPOX for people who are most at risk. This vaccine is FDA approved, and it's expected to protect folks against both MPOX clades and all of the subclads. You may be aware that MPOX is an orthopox virus. It was first detected in the 1970s in the DRC. It's endemic to countries in Central and West Africa. And the outbreaks from the different subclads of MPOX can have different clinical characteristics. Yikes. Like who they affect, and even how many deaths they cause. The current clade 2 MPOX outbreak has caused about 100,000 cases in about 122 countries, including about 115 countries where MPOX hadn't previously been reported. And that outbreak was caused by the subclade 2B. There continue to be clade 2B MPOX cases at low levels in many countries around the world. But one of the reasons that we're doing this lecture is that there's a newer outbreak of clade 1 MPOX starting in the DRC in 2023. It started on the eastern part of the DRC, but has spread into neighboring countries and some countries further afield over the course of 2024. In real life outbreaks, we believe that the chance of human-to-human respiratory spread of MPOX is very, very low, but not impossible. And so one reason that folks are concerned is that because there have been cases both regionally and outside the region, there's the possibility that we'll learn more about the clade that's currently spreading, and that learning more may include learning more about how it's spread. Because clade 1B has some different characteristics about its morbidity and mortality, it was re-announced as a FIKE on the 14th of August of this year, and that's part of what made it the topic of today's conversation. When we think about the 2 clade outbreaks, we've talked a little bit about them already. About 1/3 of the cases in the outbreak from July 2022 through May of 2023, which is the time that the FIKE was active, were in the United States. So far in the clade 1B FIKE, the cases in Africa have been about 3 times higher than in the prior FIKE. There's been higher case fatality. There's been intra-household transmission and a really high burden of pediatric infections. And it's been found not to be particularly susceptible to one of the antivirals that was used in the clade 2B FIKE. In terms of clade 2B, which, as we said, is still circulating, there's not been a marked change in weekly or monthly national case counts over about the course of the past 6 months. The death counts also have not changed, and this is very recent data from the CDC about clade 2B cases. When we think about how this shows up all over the world, the 2 subgroups of clade 1, clade 1A and clade 1B, are mostly found in the DRC. This clade 1 outbreak and its spread to neighboring countries can be seen with sort of the striped over map here. We know that in Central Africa, clade 1A patients have gotten MPOX through contact with infected, deceased, or living wild animals, person-to-person transmission within the household, and healthcare workers have gotten infections through patient care. Those clade 1 cases have had a significant number of cases in children under the age of 15, which is different than the clade 2 cases that we'd seen during the last FIKE. On this map, clade 2 is seen in orange. It's endemic primarily to West Africa. There was a big outbreak in Nigeria and then international spread in 2022, as we've talked about. About 96% of the total clade 1 cases right now are in the DRC, but we're seeing cases in about 15 other countries right now. We suspect that some of the reason that the current clade cases of clade 1 are being seen with higher number of both cases and greater deaths in children is because in the prior outbreak, a lot of folks had residual protection from prior smallpox vaccination. Smallpox vaccination has not been a thing for folks who were born after 1980. And so there's likely less protection for some of these youth because they were never exposed to that. In addition, about 40% of the kids who have been documented as having MPOX have concomitant malnutrition or malnourishment, and that's known to be a problem with pox viruses in particular for having good outcomes. In terms of our geographic distribution of cases, we've talked a little bit about this already. One of the other reasons that the Clade 1B outbreak has been of concern is that there have never been MPOX outbreaks in some of the countries we are currently seeing that. That includes places like Kenya, Rwanda, Uganda, and Burundi. When we come back to the United States, this is our real-time snapshot from Sunday of MPOX monitoring in wastewater. So there's MPOX wastewater monitoring sites the same way that there's COVID-19 wastewater monitoring sites. Currently, there's intermittent detection of MPOX with no distinguishment on this CDC dashboard by Claude in 3 sites in Grant County, Washington State, Riverside County in California, and Cook County in Illinois, and no sustained or consistent detection at any other sites. If we zoom in even further, looking just at Maryland, which is home for those of us on this call, our Maryland MPOX cases over the course of the entire outbreak have demonstrated some interesting features like geospatial clustering. About 30% each of the case totals, so 60% in whole, were in Baltimore City and PG County. The Maryland epidemic was predominantly male and MSM predominant. About 95% of cases were in men, and many were either in MSM or close contacts of MSM. And compared with the global outbreak, which across both clades has had many pediatric cases, the Maryland and US outbreak affected primarily adults. There's some research happening institutionally around MPOX. There's the clinical characterization protocol for severe emerging infections that's seeking to build a clinical, behavioral, and serologic repository for MPOX investigators, and that's being led by someone on the call, Dr. Hansodi. There's the STOMP trial, which is for an antiviral being used to treat MPOX. That's tecovir-mat. It's to understand the effectiveness of this treatment as a clinical treatment for MPOX, and the site PI for the STOMP trial, which is a multi-site study, is Dr. Hamill. And then there's the MATRIX study, which is looking at improving understanding of MPOX vaccine hesitancy, sexual behavior, and coverage gaps across key populations. It's in 5 cities, including here, and the goal is about 6,000 folks to participate, and Dr. Jennings is running that MATRIX study. If you're interested in more details about any of those, please just let me know. We're going to pivot here from sort of a global health epidemiology focus to a real clinical focus. And before I go on, I will say that I'm going to show some slides. The slides are going to include pictures of rashes. Those rashes are going to include rashes on the genitals. If you are in a context where that's going to be problematic for you, make sure that your screen is turned in such a way that it's not going to be a problem for you, or feel free to come back to our call a little bit later. So the typical time course of illness for MPOX is one of progression of both symptoms and rash over time. So generally starts with an edematome, which means that people don't feel great, but they don't feel terrible yet either. Sometimes they'll have oral lesions at that point, especially if the original exposure was dermal oral, but often it's just that folks have a little bit of malaise. The next phase of the illness generally happens about a day or 2 later, and people start with a macular rash that generally will progress to a papular rash over about 24 to 48 hours. Macular rashes, remember, are flat rashes. Papular rashes we can feel when I run our finger over them. After about 3 to 4 days, those papular bumps evolve into fluid-filled bumps or vesicles. Often clear, although the clear phase tends to be fairly brief, and then become cloudy, and it looks like they are pus-filled. Those pustules generally are uncomfortable, sometimes rated as painful, tend to have opaque fluid within them, although it's not always truly pus. They tend to feel very firm and sort of deeply seated in the skin. They don't move around when you wiggle them, and they last for much longer than almost any other phase of the rash. So they tend to last for about a week. The pustules, once they're there, don't change location. They don't sort of evanesce and then reappear right next to one another. And all of the bits of the rash tend to go through the same phase at the same time. Once the pustules rupture, they tend to scab over, and the scabs will remain for about another week. Generally, people go through this entire illness course over the course of about 15 to 18 days. Once the scabs have all fallen off, someone is no longer infectious. Until all the scabs have fallen off, they are still potentially infectious. So that's our time course of illness to give you a sense of if you're seeing an individual patient, where are they in their course of disease? This is also helpful if you need to counsel a patient about potential exposures that they may have had. Folks are infectious from the time of the infantum onward. So from the time that they start to feel crummy all the way until their rash is totally crusted over and all of the crusts have fallen off. So it can be a fairly long period of time that they're infectious for. The Health Action Network from the CDC has some guidance for you about the new outbreak, which is the following. They want you to think about geography and have a higher level of concern for folks who've recently been either in the DRC or any country that shares a border with the DRC. And just in case you are not a savant with your geography, that's Congo, Angola, Zambia, Rwanda, Burundi, Uganda, South Sudan, and the Central African Republic. And I personally have this snapshotted in my phone because geography is not my strong suit on night shifts. They also want you to think about this if someone has geography plus one or more of these other clinical signs, like a rash, particularly if it's on the hands, feet, chest, face, mouth, or the underwear area. And if they have an influenza-like illness to go along with that rash, they really want you to be suspicious about this. They want you to ask patients who have signs or symptoms of MPOX, but no recent travel, whether they've had contact with people who could or might have been in any of those above countries and could or might have had symptoms that they may not have noticed at the time of their contact. Does that feel solid for everyone? Many people are off video, so it's hard for me to tell how some of this is landing. I appreciate those of you who are giving me the thumbs up.
This is resonating well.
All right. So we're now going to go into some visual diagnosis moments. This is your last moment to click away if you're not prepared to see some rashes. So rash features often starts at the site of inoculation. And this is something that we didn't know before the most recent outbreak. Hands, mouth, and genitals are common for reasons that those are things that we often use to touch other people's bodies. And often where we touch is where the rash starts. So the tactile character, when you, the clinician, feel the rash, it's going to feel firm, rubbery, well circumscribed. It's not going to sort of bleed into the surrounding tissues, and deep-seated. It's not going to wiggle around with you sort of rub a gloved finger on top of it. The lesions are going to develop simultaneously and evolve together. So just like you've been taught in other rashes, you're going to look for, does this look like that? You certainly can scratch off a vesicle and have an intact vesicle and a non-intact vesicle at the same time, but it's very unlikely with MPOX that you'll have a vesicle, a papule, and a pustule all in different places on the body. There is a little bit of nuance to this when it comes to mucosal lesions, and I'm going to show you some pictures to help anchor our discussion on that. The subjective feel, meaning what the patient is going to tell you they're feeling, is that these lesions mostly hurt. They tend to hurt all the way from the time that they start right up until they are crusting over, and then they become a little bit itchy, although not intensely pruritic, the way that you might see with, for example, varicella. Because of the discomfort, pain control is going to be an important clinical consideration when managing these patients. So a little bit of nuance about mucosal lesions versus non-mucosal lesions. Cutaneous lesions go through really in a very standard way that progression that I just talked about. But mucosal lesions don't always do that. Mucosal lesions sometimes will look just like an ulceration or an erosion without any induration around it. Sometimes can look like a papule or a nodule, like a syphilis chancre, and sometimes can have almost a pseudomembranous appearance, which is that sort of sluffy, not really an ulcer, looks like there's going to be an ulcer under it, but when you wipe it away, there's just sort of like a soft, fleshy bump under it, almost like a candidal kind of a lesion. All of the mucosal lesions do not form a crust. So if someone has an abundance of mucosal lesions, you can tell them not to expect the crust formation that they would expect to see if they're healing their skin lesions at the same time. Gonna jump forward and show you sort of what does this actually look like. So typically folks will have fever and other prodromal symptoms around the time that they have these first bumpy looking rashes. It can occur before the rash that they have that influenza-like illness with chills, lymphadenopathy, malaise, myalgia, but sometimes it's not present at all. These little bumps here could be mistaken by a patient for folliculitis, right? Or just, you know, a zit. And many times it's not until the bump starts to umbilicate, as you see here, that folks realize that something different is going on. As the rash finishes its umbilication, it tends to form, and this is sort of moving from fluid filled to crusting, this bottom left picture here. Once it crusts, the crusts are pretty adherent. They're not actually all that easy to knock off. And then once the crust is off, often you have some residual post-inflammatory hyperpigmentation. The rash, in contrast to some other illnesses that we may be aware of that can be sexually transmitted, doesn't always appear on palms and soles. If folks have involvement of the mucosa inside their rectum, sometimes they'll present with dyschezia, pearlet stools, bloody stools, rectal pain. And if they have relatively few rash findings outside their perineum, it can be very hard to tell that that's what the disease process is. So a good inspection of the perineal area in folks who are having those symptoms of rectal concerns can be really important in making sure that the illness is detected and diagnosed correctly. In terms of looking at some mucosal lesions, this is an example of sort of those superficial ulcers in the area around this patient's anus. And you can see that the skin in between the lesions is really not involved at all, which is different than a number of other ulcerative genital diseases, like, for example, HSV, where the skin in between the lesions tends to be pretty indurated. In this case, the skin in between the lesions is really intact, and you just have those ulcers themselves that are very painful. You can also see these pseudopustules, right? You can see that they start umbilicated, like this lesion up near the top of the vulva, and then they become, that umbilication starts to evolve into the crust that'll eventually form. You also can have these that look almost like shank ears. So this is our genital pseudopustules. And I'm happy to send the resource from which these images came, although the individual photographer is cited below. In terms of thinking about sort of zooming out from these deep zoomed in pictures to seeing how it can look on other skin. So it can be as simple as 1 or 2 lesions just on any point of skin where folks had infectious contact, all the way up to clusters of papules or pustules. And as I said, the reason that there's so many photographs of genital MPOX in this is that the initial outbreak tends to be at the site that someone contracted the infection. So for folks who their skin-skin contact occurred during sexual activity, the first outbreak often occurs on the genitals. The genitals obviously also are a nerve-dense area, so it's particularly unfortunate because this is a pretty painful condition. Reinforcing one more time that our MPOX lesions typically develop at the same time and evolve together. So when I'm showing you photographs of people with clusters of lesions, something that you're going to notice is that generally all the lesions are at the same stage. That's not by accident. That's not based on just me selecting photos that show that. That's part of the natural evolution of disease. So when we see in this picture of this person who unfortunately has a very dense outbreak of facial rash, we see that essentially all of them are at the same stage of sort of pseudopustular, starting to develop a little nubbin in the center that's that umbilication. That umbilication will eventually turn into a crust. We see the same thing in the picture on the bottom right. And we see examples of the rash on a variety of folks with different amounts of melanin. One thing that's really important for everyone as a frontline provider is to make sure that when you're studying rashes, that you're studying how they appear on lots and lots and lots of different skin tones to make sure that you're able to pick this up, no matter how much melanin someone does or doesn't have in their skin. Findings can be pretty subtle. It's often helpful to ask the patient, are you feeling any sore spots anywhere else? And that can sometimes help you detect, for example, the lesions on this patient's hand, which I think are sort of subtle in the photograph. It also may help you detect lesions that you might have thought were an alternative diagnosis, like the lesions on the shoulder of this patient. Sometimes the lesions are going to be really, really classic appearing, and you're going to be like, there's nothing else that this could be, as in this photograph from Nigeria. And sometimes the lesions are going to be totally plausibly, deniably something else, like in this photograph from Spain. So this is one of those unfortunate diagnoses where if you have rash plus ILI symptoms, plus any possible geographic link or epidemiologic link in terms of contact with the community that's experiencing an MPOX outbreak, you want to have that terrible term, a heightened level of suspicion for this diagnosis. Something important for us to think about is, what if we get this wrong? What else could this be? So some important differentials to consider include varicella, although in varicella, we tend to have crops that evolve rather than sort of this simultaneous evolvement. It's important for me to note that in about 12% of patients, there appears to be simultaneous varicella zoster and MPOX infection. And that's unfortunate for a variety of reasons. There's a number of theories as to why co-infection seems so much more common with VZV and MPOX than with any other two viruses that we're aware of with MPOX. Some of it may be true co-infection. Some of it may be that MPOX infection is a pretty big stressor on the immune environment, and we're actually seeing secondary shingles at the same time as MPOX infection. Some of it may be that immunocompromise from one of the viruses is leading to secondary infection with the other virus. It's not well established in the medical literature right now. But if you're looking at someone and you're like, boy, this really looks like both chickenpox or varicella and MPOX, it might be both. And so feel free to keep that differential open for yourself. If you see someone and you think, boy, this person has a lot of rash for MPOX. I thought that MPOX typically has a number of small clusters of lesions and relatively rarely is sort of like whole body. That's when you may want to start ringing some alarm bells for smallpox, which the rash looks very similar, almost clinically indistinguishable from MPOX, although it tends to involve a lot more lesions. If you're seeing smallpox, that is a big, big, big wake up everybody emergency. So far as we're aware, there is no circulating smallpox in the world right now. And were you to see that, that would be a pretty big spike as well as a emergency, because it's believed that right now smallpox could only reemerge based on deliberate action by some form of bad actor out in the world. Other things to think about when you have a mystery rash, plus an influenza-like illness, plus someone who's having skin-to-skin contact with new friends, is syphilis. Syphilis is allowed to look like anything. It's allowed to look like MPOX. It can produce some of the same genital lesions that look very similar to the lesions that I've shown you today. So it's important to have on your differential. Patients who have acutely acquired HIV tend to present with this thing called acute retroviral syndrome. ILI symptoms plus an exanthem plus sexual contact can equal acute retroviral syndrome. Again, another important one to include in your differential when you're managing a patient who has this concern. Symptomatic genital HSV doesn't really look that much like MPOX, but is really painful and tends to evolve in the same body areas that can be affected by MPOX. One way to distinguish it is what I was speaking about earlier, that sort of involved skin in between the lesions versus involvement of just the lesions. In terms of laboratory testing, you're going to want to evaluate all suspected cases that are related to the DRC or neighboring countries with lab testing rather than just clinical diagnosis. If there's no epidemiologic link that you can find, clinical diagnosis is sufficient for MPOX. You should know your local policy about MPOX testing and samples. The CDC currently recommends collecting 2 swabs per every 2 to 3 lesions to make sure that there's enough specimen availability for clade-specific testing. And newly and different than what was recommended previously, the CDC is recommending avoiding unroofing or aspirating lesions due to the risk of needle stick and harm related to using sharp things around tender spots, often in sort of folded or narrow parts of the body. It's important to know in advance where to find your institutional guidance and linkages to policies and procedures to guide your infection control, your isolation, testing, referral. It's going to allow you to cognitively deload when you're caring for a patient with any emerging threat, but particularly with MPOX. I've screenshotted here our local institutional guidance for MPOX, which can be found just by searching MPVX, MPOX, or the old term monkeypox on our internal guidance within EPIC. In terms of treatment strategies, you're going to want to consider referral for treatment outside of your home institution if someone has really severe manifestations. So what does that look like? Ocular infection, neurologic complication, myopericarditis, They can't defecate or urinate because their mucosal lesions are so painful. They can't eat or drink because they have oral lesions and they're so painful. They have uncontrolled viral spread because they have severe immunocompromise, particularly if they have a concomitant advanced HIV. Another concomitant condition that can be really problematic is if someone has uncontrolled eczema and they get MPOX. We've seen some very, very severe superinfections in folks with bad eczema, and they can get uncontrolled viral spread. Those are folks where you want to think about potentially referring. For non-severe infections, unfortunately, there's no treatment that's approved specifically for the MPOX virus, MPXV. Most patients require pain control and need supportive care as well as encouragement about their disease because it still is a stigmatized disease. Strongly consider helping them to help their contacts get linked with vaccines because you can interrupt chains of transmission that way if transmission didn't occur during a prior contact. For severe infections, tecovirimat is an antiviral. It's an investigational drug. It's being studied in the STOMP trial that I mentioned earlier. So far, there's about 7,100 patients who have been studied. If you scan this QR code, it'll take you to the published data from the STOMP trial so far. Unfortunately, this antiviral is thought not to be effective for Clade 1B. So talk to your local infectious disease team if you have a patient with severe infection and you suspect that they may have an epidemiologic link to the 1B clade. Let's say that you've gotten this patient diagnosed, you've gotten them tucked in with all of the diagnostic testing that they need, if they need any at all, and you're going to try to get them home in terms of symptom control. They're feeling all right. You're going to want to discuss isolation with them. Person-to-person spread remains the most common way that this is spread. You've got to make sure that you discuss with your patients that the rash is infectious, can sicken others, that it's typically transmitted by direct contact with either the rash, the sores, or the scabs from someone who has MPOX. Fomite transfer absolutely does happen. So that means that the rash can cause infection by someone touching the objects, fabrics, or surfaces that the patient has touched. That means that bed linens, towels, those kinds of things shouldn't be shared and need to be washed after they've been in contact with the person with MPOX. Droplet spread is thought to be only a feature during very prolonged face-to-face contact, like a kissing session that goes on for a little while or other very close face-to-face contact like you might have with a baby. And so we encourage people with MPOX to avoid that kind of contact with others until all of their lesions are crusted and have fallen off. If you would like a pre-made resource for home care of skin, the American Academy of Dermatology has a PDF of discharge instructions that are ready to use, ready to print, ready to hand your patients. It's available at this QR code. The basics of this are that cleansing, creating a moist healing environment, and protecting the skin at the borders of a large wound, as well as some guidance around how to care for the perineal skin, are all really nice features of this set of discharge instructions. And I know that often this is a challenge when we're discharging people with emerging infections, is that we don't have good guidance for them. I thought that this guidance was really excellent, and I wanted to make sure that you all had a link to it. A little bit more just-in-time clinical support, important for MPOX, but also just sort of generally important. The CDC MPOX hub is at cdc.gov, poxvirus/MPOX/clinicians/index.html. It's linked here, and there's a lot there that's really helpful if you're managing someone who has MPOX. If you're managing something that's not covered in that MPOX hub, the CDC Poxvirus Emergency Operations Center is at this phone number, and they answer it 24/7. So if you truly are having a cluster of cases in your emergency department in the middle of the night, and you're like, I don't have any local guidance, and I really want to make sure that I take care of this correctly, that's what the Emergency Operations Center is for, and you can reach out to them. Save it in your cell phone. Lastly, if you need a state level 24/7 epidemiologic contact, this link from the CSTE has epidemiologists on call for your state. These are the folks whose job it is to respond to concerns that you might have as a frontline provider in the middle of the night about MPOX or other emerging infectious diseases that you might be called upon to respond to. And I wanted you all to have that resource as well. that's just about it in terms of my time. And I want to be respectful of everyone who's paid such good attention and engaged in the chat and by being on video. Thank you all for being a fabulous audience. If you don't mind scanning the QR code that's displayed on your screen to reach a feedback survey. If you have any questions, please feel free to put them in the chat, or if you don't want to share them publicly, feel free to email me. My email is displayed on the screen. It's apousso and the number 1@gh.edu. Thanks again for the opportunity to chat with you today about MPOX, and I appreciate your time.